Okay, we'll start a meeting. Welcome everybody to this extraordinary meeting of the Hambleton, Richmond, Whitby Clinical Commissioning Group to consider the report and recommendations for the children's and maternity services at the Friars Hospital. Just some housekeeping. There is no fire alarm planned, tester planned this morning, so if the fire alarm does go off, please exit through the door behind you and congregate in the car park. The toilets are again behind you down the corridor. Before I introduce the governing body members, I'll just remind you this is a meeting held in public and not a public meeting. So while the first 20 minutes of the meeting is given over to questions that have been submitted, we will then enter into the meeting proper and conduct the meeting in public. Can I just introduce the governing body members? I'm Henry Cronin, the lay chairman of the CCG.
I'm Vicky Playdale, I'm a clinical chief officer of the CCG.
Debbie Newton, chief operating and finance officer.
I'm George Campbell, I'm the deputy chair of the CCG.
I'm Jo Harding, I'm senior delivery manager and lead nurse for the CCG.
I'm Charles Parker, I'm a GP.
I'm Jane Ritchie, I'm the lay representative for Richmondshire.
Katie Needham, consultant public health.
Sarah Ferguson, senior delivery manager.
Ken Elliott, lay member for Hambleton.
I'm Sally Burton, I'm the interim director of adult services for North Yorkshire County Council.
I'm Linda Lloyd, I'm the lay representative for Whitby area.
John James, secondary care doctor.
Ken Reedshaw, lay member responsible for governance.
Mark Hodgson, I'm GP.
Maria Lawson, executive assistant.
Thank you. Can I just remind people to speak clearly and loudly? The meeting is being recorded and taped, so please press your buttons when you speak. As I said, the first 20 minutes of the meeting are given over to public questions, and we've had 6 questions submitted. We'll go through these in turn. First of all, Mr. David Stokes. Mr. Stokes here? No? The question was, as a member of the public, I would like to know if A&E department at the Friars Hospital will continue as present, accepting all sick children. And secondly, I'm aware, due to the recent proposals, that there will be limited paediatric cover. Therefore, how will this affect the community when faced with a sick child?
Okay, I'll answer that question. Sick children should go initially to see their GP, contact their GP. So as a parent of a sick child, the first thing to do is to phone your GP practice or the out-of-hours service. If a family phone 999, the ambulance that responds will then make a decision looking at the child and will either take that child to the general practice or GP out-of-hours service, or they will take them, if they're really seriously ill, to the nearest inpatient unit. That will not include the Friarage. If you live in Richmond, that would include, even now, you would go to Darlington because that is the nearest unit. So the ambulance will make a clinical decision about whether that person needs to go. If a sick child arrives at the Friarage Hospital, A&E department, they will be seen in hours in the short stay paediatric assessment unit if that's required, and out of hours they will be seen by the GP out of hours service. A clinical decision will be made about the child, and the child will be either sent home or they will be sent on to an inpatient paediatric unit if they need to be.
Paediatric cover.
I think what I would say is that if a child is unwell, the right thing to do is to phone your GP. GPs are local, they're in your community, and the GP out-of-hours service is also there, and they are there to respond to children being unwell. Most unwell children can be seen and treated by their GPs.
Thank you.
Excuse me, Henry. We didn't answer the A&E question. Did we answer the full A&E was going to stay?
Yeah. All the other A&E services will stay as they are now.
Okay. Can we have the question from Councillor Tony Duff?
First of all, I'd like to hear from you whether you're stepping down, this is what I'd heard, and if so, why. Now, in my opinion, the NHS should be run for the benefit of the patients, not the convenience of doctors, and I think this is a basic principle. Also, 2.7 million, which is the figure that has been quoted to continue the maternity and paediatric service of Friarage, is not a sustainable figure. Research up and down the country on similar small hospitals produces an average figure of £300,000. That's a lot less than 2.7 million. The Working Time Directive, the dreaded Common Market, has been regularly quoted. I cannot think why. Consultants are entitled to opt out of the Working Time Directive, and Jill Moulton told me at a meeting the other day that all in this group do so. That saves 3 consultants. Well, I don't know, I've seen in the paper this morning doctors getting an extra fund for every year, but it will save at least £350,000. Now, if services are transferred to James Cook, I understand that a new operating theatre, a new ward would be required. Original cost was quoted at 6 million. Extraordinarily, that figure has now come down to 1 million. Can't think how. I was also told that no more doctors or nurses would be required. Doctors possibly if they are removed from the Friarage. But how can you run another operating theatre, another ward with no more nurses? Frankly, unbelievable. Recent research from Elgin to Exeter has shown little or no problem in recruiting doctors. A small hospital in Devon said it was oversubscribed with applications. It is therefore hard to believe that the commissioning group, when they say recruiting is difficult, if not impossible. How hard have they tried? And I would suggest a boot behind the HR department. Dr. Pradle has said she doesn't know what people want. Well, as far as I can see, she's in good physical health and no problem with eyes or ears. So it's incredible. There was a march here in Northallerton, 5,000 people. A petition of 10,000 people. Numerous submissions and council resolutions all saying keep the services. She did a survey which offered a bad option at reducing the services at Friarage and then a worse option at reducing them even more. Out of a catchment area population of between 20,000 and 50,000, depends how you decide the catchment area, she had 70 replies. Not very significant. From the outset, the commissioning group have ignored the views of thousands of patients or potential patients. The Friarage has the best record of live births and paediatric treatment in Yorkshire. If you go ahead with this plan, there will be a number of babies born in lay-bys on the A19 or worse. Also, to transport a mother in difficult labour in an ambulance from the Friarage to James Cook is not regarded as a good idea by anyone. Ambulances have a hard suspension and there is a great shortage of them in Yorkshire. Learn from other small hospitals all over the country and keep the services at the Friarage.
Thank you. I will answer one of those questions, and the other was statements rather than questions. I hope you stay for the meeting because we'll be addressing each of those issues as we go through the report. The one question I will answer is my stepping down from the role, which I made a decision at the end of last year, which I informed the governing body at that time, because I have personal commitments this year which will not allow me to devote sufficient time to the CCG. So it's unfair on them for me to continue in a role which I feel I won't be able to give them sufficient time. For the rest of your statement, I hope you will pick those up in the meeting, and then if we don't, at the end of the meeting, please come and see me and we will do an understanding of this.
Just particularly answer the question about me not knowing what the public think. And I think it's an interesting dilemma. We all think we know what the public think, but the truth is that Hambleton and Richmondshire has a population of 144,000 people. So actually, even if you add up all the people on the march, all the people who who filled in the questionnaire, all the people who signed a petition, many of whom came to me and said they signed that petition to support the future of the Friarage in general, that's what they thought they were signing, not around paediatrics and maternity individually. If you add everything up, it is still a tiny minority of our general public. And it is a question for us, I think, in a democratic society about how we actually hear what the silent majority really think. What I would like to say is I think probably the people who know the most about what people who use services the most think are actually GPs. They see 50 patients a day, which is probably, if you add it up across our area, 20,000 people a week. They are the ones who day to day talk to patients about their services, and it is the GPs, therefore, who use that information when they made their decisions.
Can I now move on to a question from Mr. David Tucker? Mr. Tucker? Not here. Okay. The question Mr. Tucker has submitted, if I can find it. Yes. Does the CCG accept that if the intended midwifery-led unit at the Friarage Hospital has insufficient midwives as a consequence of a national shortage of midwives, or has insufficient numbers of low-risk mothers choosing to use that service, there will be no maternity services at the Friarage? So there's two parts to that question. Will we have enough midwives to staff it, and will enough mothers choose it if it is to be a midwifery-led service?
We've been reassured by the Trust that at the moment they have no problems with midwifery staff at the Friarages. It's obviously an ongoing issue, and they are working hard to make sure we have good maternity staff at the Friarage. In terms of usage, we've always said very clearly that if we follow the Royal Courier's guidance, what we need is about 300 deliveries a year to make it safe. That is up to patients and the public to choose that service. And actually there are thriving units around the country. If you look at Kendal, in 2011 they had 400 deliveries there. People choose it, they like it. If you look at the website about patient choice, a lot of very good feedback about it, even though they have to transfer to Lancaster, which is actually further away than James Cook, when they run into trouble.
Thank you. Next question is from Councillor Blackie.
Thank you. Good morning. I followed the instructions on your website, which indicated that you were only interested in questions, so I put forward questions, any questions. I put forward 5 questions, and you've rejected 3 as being inappropriate. I know which 3 you've rejected as being inappropriate. I presume I still can't ask them today. Is that right?
As you know, I emailed you yesterday, Councillor Blackie, and asked you to ring me if you were unclear about why they were inappropriate. I'm quite happy to say why they're inappropriate now, if you want to, but I would rather you stick to the questions you said you're going to submit.
Well, if you're quite happy to say why they're inappropriate, can I read the question and you can say why it's inappropriate?
No, because I told you I'm chairing the meeting and I thought they're inappropriate. That's it.
Well, then why are they inappropriate then, please? Can you say that, please? And then I'll ask the questions that you say are appropriate.
I'm not going to get a debate about it.
Well, you've just offered to say it, you'd say.
I think they were personal statements questioning the integrity of the staff who deliver the service at the present time. And I find that unacceptable. It isn't something we as a public body, we don't question people's commitment or integrity. We do question their decisions. We don't attack the person, we attack the issue. I felt you were attacking the people.
There's not one single name mentioned in my questions at all. We're all about actually organisations. But anyhow, I will accede to the chair. And then if I now move on to my questions, but can I say, do not worry, I'm not putting in for your job as chairman of this CCG, just in case you're all looking rather worried there. And the other issue is, at another place and another time, Dr. Playdale, I'll explain what the silent majority wants. You clearly haven't listened. Number 1, what account and impact assessment on their peace of mind has been made by the Hambleton, Richmondshire and Whitby Clinical Commissioning Group of the deep-seated bond in existence between the local communities and their local hospital, our wonderful Friarage Hospital? Given this bond has been built up over many years and through many generations of families, and the first-class services at the Friarage that have won their complete trust and confidence. Services you are proposing to dismantle at a stroke. There's a second question. Do you want to answer that first and I come back?
Yes, certainly.
Thank you.
In the report, which we're going to go through in detail, you will find the impact assessments we've undertaken in relation to the proposals and of the views of the people. So as we go through the report today, you'll hear that.
Will you highlight then those areas of the impact assessment that deal with my particular point? It's a point, Mr. Chairman, that's been recognised by Dr. Playdell and others at various meetings.
And as I say, if we haven't answered that by the end of this meeting, please come back to me.
I will do. How many of the small hospitals visited by me and others who are here today, as shown in the Richmond District Council alternative model of provision, has your HRW CCG visited yourselves to find out firsthand how they are all very positive and determined to continue their safe, sustainable and affordable 24/7 consultant-led services? Can I have an answer, please?
John, we visited Banbury with you. I think you'll remember that, and I know that the Trust have sent people to many trusts up and down the country to look at models. We didn't repeat your visits because we trust your report in terms of describing the services, and we didn't want to waste public money with us going up to repeat the work that you've already done. What we did do was we had at length conversations with the commissioners of the services up and down the country, and we did that by phone. And actually, one of the models, as an example of this, one of the models we were very interested in was the hospital in the north of Scotland, in Elgin, because actually that's one of the only units that runs a consultant-only unit with no middle tier, which is actually what we have at the Friarage. And in discussion with NHS Grampian, they pointed out to us that they are at the moment undergoing a review of their paediatric services because of the same concerns we have about safety and sustainability. And if I could read a little bit of the letter that they wrote to us, this is a formal letter, they said that they are going through a significant public engagement as we speak. I cannot preempt the process. It's fair to say that the present model is likely to be the present model is unlikely to be sustainable into the longer term. So they are basically going through exactly the same process that we are going through. We therefore couldn't shape a new model for here based on a model that is being reviewed in Scotland.
I just wonder then, please, because I am allowed a supplementary question, am I? It says here, despite the intensive work to understand different models from around the country, I'm grateful that you trusted what we put forward, although you didn't actually go test the extent of trust to scoring it in the end. I just wonder how intensive work squares with not visiting at least the Elgin Hospital itself, because if you had done, you would have found that just last year, NHS Grampian included the hospital, Dr. Gray's Hospital at Elgin, as part of their model of provision of 24/7 consultant-led services. So I just wondered if you spoke to the right people on the telephone, and if you've been to the hospital, of course, there couldn't have been that mistake, could there?
We actually looked at the papers on the website for NHS Grampian, and if you look at those, there is a board paper to NHS Grampian about the future of paediatric services. And this is the most up-to-date. It happened actually, we had a discussion with them after you went to Elgin, and what they were saying is they have great concerns about the future sustainability and safety of that service.
Okay, thank you. The next question is from Councillor Parsons.
Thank you. Why wasn't Richmondshire District Council or the two other proposers offered the chance to meet with the representatives from the GP Council of Members to discuss their concerns with the CCG's proposals and the merits of their own proposals if they were to be the decision makers on such a hugely important matter? And at what point were the full documents that were handed over to the CCG by the three proposers by the 25th of November 2013 shared with those individual GP practices? And secondly...
Can you answer that question first and then come back? Thank you.
My understanding was that this question was put on the Facebook, the Facebook page, and the CCG did do a reply on our website. But just to go through it again, the CCG held 2 clinical review meetings with the Richmond District Council and other proposers of additional options. And this was done with a range of clinical staff and a range of organisations, just not with primary care. The CCG then independently assessed via NCAT and all information along with the scoring system and shared this with practices. We cannot pull all of primary care out of practice to go and meet with people during working hours.
I think you're answering the second question there, George, sorry. It was the first one about the involvement of the council members, really. Yeah, that's fine, yeah.
And it's the dates of the website.
Anyway, so on the 23rd of December, all GPs were emailed a briefing pack which included a presentation outlining the format of the extraordinary council members' meeting scheduled for the 7th of February this year. Key dates and actions for each practice needed to undertake were included in the email. Embedded within that presentation were full copies of each of the 3 additional options, as well as the original 2 options from the pre-engagement phase. A link was also included within this email to the additional options as published on the CCG website. On the 23rd of January this year, GPs were sent an additional pack containing overviews of the clinical review meeting held on the 18th of December last year, and the independent clinical report back from NCAT. Also included were clear and concise decision-making criteria and filter questions for scoring all 5 options, plus information relating to the cost of implementing each option and the additional 3 options.
Thank you, George. Could we have the second question, please?
Yeah, thank you. Can I ask that you forward the email that you sent around all the practices to me? Thank you very much.
It's on the website.
It's on the CCG website now.
Okay, but can I ask that somebody forwards it to me?
It's on the website.
Thank you. I'm not asking if it's on the website or not. I'm asking for somebody to
forward
it to me. Thank you. Gosh.
Would you like the presentation as well that accompanies
yes, please.
that, which has got all the attachments, and we're really happy to transparently share all information.
Yeah, that's perfect. Thank you very much. I'm not suggesting you're not. How far open and rigorous is a process where GPs meet in the privacy of their surgeries and are given selective papers to discuss amongst themselves with options to score, the impact of which will change the health landscape for thousands of people, and then it is deemed acceptable that if they don't attend the decision-making meeting in person, they can either email or telephone their thoughts or scores back to the governing body itself instead?
Sorry.
I'm answering that one. Yep. The process of the decision-making process by the CCG Constitution was discussed and shared at the clinical review meetings that were held with Richmondshire District Council, and no issues were raised at that time about the process of the decision-making. The council members made their recommendations to the governing body, knowing that this would then be held in public, and that's what we're doing today. As has been said before, we emailed every practice to ensure that we had the views of each practice and that they were represented, the views of the practices were represented at that council and members meeting. The individual practices discussed it between themselves as partners, and the individual representatives that were able to make the meeting then gave those opinions. But as Dr. Bladell's already said earlier, the GPs have been discussing these issues with their patients over the year or two that this process has been running, and have gathered a lot of information and views from the members of the public, which have helped mould their decision making. And I think we, as has also been said, we have to accept that not every practice would be able to make the meeting due to the rurality of the area, but that we made sure that every practice was individually contacted and that we had the views of every practice, and all practices did vote on the issues.
Okay, thank you. Can I now ask Councillor Robinson? He's submitted 2 questions. Councillor Robinson.
New options were submitted to the CCG, as the RIP had stated could happen. Why, based on the judgment of NCAT's desktop review, was the IRP's guidance ignored and those options not evaluated? The IRP stated that it was important that the formal consultation was conducted and completed in a way that engages all interested parties in a fair, open and rigorous process that seeks the best possible solution. From this transcript of the CCG governing body meeting of the 7th of February meeting, it appears that some of the GPs did not feel that even the CCG's own option 2 was worthy of scoring and did not score it whilst others did. Several GP practices throughout that the RDC option was a real alternative, as did William Hague, MP, and even the NCAT letter had many positives about RDC proposal in it, but intimated that it required further work and detail.
I think, first of all, if we just outline the IRP letter, what it actually says is that the consultation may also wish to invite new options and not limit respondents to those listed. Any new options put forward can be evaluated post-consultation in line with agreed criteria. And what we did was we evaluated those options in exactly the same way as we had evaluated the previous 7 options we started with during the engagement phase. And that evaluation included 3 filter questions at the beginning, which only meant that we had to have an agreement that the option was potentially sustainable and safe before it was scored by the GP practices. And that's the same as we did during the engagement phase, and has always been on our website. So we went through exactly the same process. What NCAT said was that none of the additional options were safe and sustainable, and therefore they were taken out before they were scored. NCAT did a tabletop exercise this time, but they have visited twice. They know the issues here very well, and I think you would agree that their response was very detailed. So using their criteria to say whether or not these options were safe, we used those to inform the first 3 criteria before we went to scoring. Some of the practices didn't score option 2, it's true, but the majority did. What we needed was to have, as you do in any, we have a majority, it's in our constitution, of 51%, and 19 out of 22 practices scored all the options, and I think 2 practices didn't score option 2. So we have a majority of practices who followed the governance and scored all the options.
Thank you. Second question, Councillor Thompson.
Just to come back quickly on that, you could have used another organisation other than NCAT, and why are other hospitals operating?
Well, I think we're going to cover that in our
Okay.
report.
All right.
Please.
Under your proposals, what will happen when a mother in labour arrives at the Friarage too late to transfer?
I think that's what would happen if they go anywhere. I mean, if they arrive at a practice and as a GP, I've delivered babies in the practice. I mean, if somebody arrives at a place where and they're too late to go anywhere else, then everybody will help them deliver the best they can and organise an ambulance to transfer them to where they need to go. And that is true. I think that's a question for any health centre anywhere, and the Friarage would respond in the same way.
Okay, thank you. That closes the first part of the meeting, taking questions from the public. We are now entering into the formal stage of the meeting, and we'll begin with the apologies for absence.
Duncan Rogers.
Okay, thank you. Item 2 is declarations of interest, please.
My brother, Simon Playdale, used to be the Chief Executive of South Tees Hospital Acute Trust. He's now on secondment to the NHS Confederation, and his contract with the Trust finishes at the end of March.
My husband works at the Friarage Hospital. My son is employed by North Yorkshire County Council, and I am a Commissioner Governor on the board of Tees Essex and Wear Valley NHS Foundation Trust.
Sorry, I should also add that I'm a governor on the South Tees Hospital Trust Board, and I'm there as a Commissioner Governor.
I'm a GP in Whitby, and I'm a partner in the practice, and uniquely for me, Normally I have a long list of conflicts of interest, but for this agenda I have no more.
I have no conflicts of interest.
I'm a GP partner in Topcliffe, and my brother provides independent financial advice to health trusts and local authorities.
I'm the Honorary Secretary of the Upperdales Health Watch representing Burton-cum-Walden Parish Council. I'm the Voluntary Sector Representative of the Upperdales for the North Yorkshire County Council Richmondshire Area Committee. I'm a Director of the Elm House Trust and the Vocational Learning Trust, the subsidiary of which provides space for the County Down Health Watch and other health providers. And I also possibly have shares in health organisations like Glaxo, but at any one time I have no idea what.
I have no declarations of interest.
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 I'm Chairman of Rural Action Yorkshire, and I have shares in the Redex Pharmacal.
I'm a former employee of South Tees Foundation Trust, for which I work as a consultant paediatrician. My son is a local GP.
I have no declarations of interest.
I'm a local GP at Aldborough St John. I do out-of-hours work for Harrogate District Foundation Trust. I carry out a musculoskeletal clinic for South Tees Hospitals Foundation Trust, and my wife is an occupational therapist at the Friary Hospital in Richmond.
I have no declarations of interest. Thank you. We're now going to enter into the next stage of the meeting. The first thing I want to do is just point out the role of the governing body today. The governing body has three accountabilities. We're accountable to the public, including North Yorkshire County Council Scrutiny Committee and other such committees. So in the report, we need to reflect the views of the public on the issues and make sure those views have been taken into account in making the recommendations we're considering, and which we will vote on later. The second accountability is to council members, in that the 22 practices that make up the CCG have made a proposal or decision to us. We have to make sure when we consider the report they followed due process, they've considered and analysed the issues and considered the evidence available. And in doing so then, in making their proposal to us, we can be assured that they've done so using those processes. The council members also have a role as laid out in the CCG Constitution, which has been referenced already, and how they make decisions. Our last accountability is to NHS England, in that we have to fulfil our statutory obligations in regard to carrying out the consultation, and in regard to the Constitution and how we've delivered our Constitution as laid out in the Health and Social Care Act. The Secretary of State has set 4 tests for all organisations when they're considering reconfiguring services, and we have to satisfy ourselves that we've met those tests. So as we go through the report today, we have to keep an eye, and ask the governing body to do so as we go through, that they keep those to the forefront of their thinking in how we consider and make decisions on this report. We have colleagues from South Tees Trust today who are on the front row here, and when we consider a report, we may ask them for any clinical or expertise advice, so that we may involve them in that process. The way I'm going to conduct the meeting, I'm going to summarise each section of the report in front of us. And at the end of each section of the report, I will then ask for questions and comments from the governing body. The first thing I'm going to do is just give some background and history to this. In 2011, there were clinical concerns about the services at the Friary Hospital for children and babies. Central to those concerns was the safety and sustainability of the services going forward, associated with meeting standards to provide a safe service and having an appropriately skilled and resourced workforce. In 2011, at the end of 2011, the CCG, still in shadow form at that point, sought the involvement of the National Clinical Advisory Team, NCAT as it's called. This is an independent organisation that's part of the Department of Health and advises NHS services on plans around reconfiguration. It contains clinical experts with knowledge and expertise in the particular areas which they advise on. it was recognised that the issues facing paediatric maternity services at Friars are complex. And I think the staff who put together today's report need to be congratulated in pulling together a very complex set of issues, and that's Sarah Furs and Shirley Moses. Following those considerations and those concerns, in April 2012, the CCG began an engagement process with our public and key stakeholders over a 3-month period to discuss the issues facing the services at that time. And I'm going to outline the principles underpinning our approach to that process. The first principle is that we commission services that are safe and sustainable. The second is that we work in an open, honest and transparent way and not shy away from difficult issues. That we need to demonstrate commitment to a safe and vibrant future of the Friars Hospital. That we need to develop community services to provide care as close to people's homes as possible when it's clinically safe to do so. And our last principle that we abide to is that we use public money responsibly in the commission of services. So the history is long and it is complex. And as we go through today's report, those issues will come to the fore. I'm going to move into section 2 of the report. Before I do so, is there any comments or questions from the governing body on any of those areas I just covered?
Chair, as a lay member, it was quite important that the documents before us made sense from a community sense. So I would like to say thank you to the people that put the document together, because for us to make a decision, the papers had to be clear and not full of medical jargon, and this is what they did. Also listening to the debate from a lay perspective, because I don't have any medical training whatsoever, I'm from the community. It is important that this board has had information that has been downloaded to myself and our other representatives in an easy manner to understand.
Thank you. Is there any other comments, questions? I'll then move on to section 2 of the report, which is from page 17 onwards. This describes the current service model, which is of a paediatric outpatient inpatient service of 14 beds, a labour and postnatal ward, and a 10-cot special care baby unit, antenatal and postnatal clinics. The unit caters for about 1,260 births a year, which makes it one of the smallest in the country. The paediatric ward at this time has low usage through the night, with approximately 1,400 non-elective admissions per year. The paediatric service has no middle grade doctors and relies solely on junior medical staff out of hours. The maternity overnight care is reliant on 6 middle grade staff with no juniors, and the majority of those staff are locum, and what locum means is they're agency staff, not employed directly by the trust. So when we were considering the services as they stood, the CCG considered the following issues as being of a priority to us. That the safety and quality of the services is our #1 priority, both now and in the future. It cannot allow a situation where the quality of the service at the hospital depends on what day of the week it is, what time of day or night it is, or what staff are available. It is important to achieve safe services, therefore the most senior, experienced and specialist staff need to be available on a 24-hour, 7-day basis for patients who need them. And we need the right balance between community care close to people's homes, as well as preventive and supportive services. I want to take any questions on that section of the report about the current service provision. Okay. I'll then move on to the case for change from page 21 onwards. The National Service Framework for Children, Young People and Maternity Services highlighted the fact that recent advances in healthcare through intervention and surveillance, increased health awareness, improvements in technology, medication, treatment and ongoing support was resulting in less children needing hospital care beyond short-stay assessment and treatment. For children with long-term conditions, support in the community provides better clinical outcomes and is less disruptive for both the child and their family. Having the right staff with the right skills in the right place at the right time is fundamental to providing a high quality and safe service. Therefore, the Royal College of Paediatricians and Child Health have recommended minimum staffing levels to achieve these safe and quality services. Also, having the right level of senior staff in units dealing with volumes of activity appropriate to their skills maintains their competencies, which is not possible in smaller services such as a FireEdge, which simply means if you don't use your skills consistently, there is a danger you become rusty, and therefore when you have a critical situation, you may use the wrong interventions and may jeopardize clinical safety. Also, having a well-resourced and active service provides a training environment for future senior staff and consultants. The FireEdge is unable to attract that criteria to be designated the training environment. And lastly, it has come up several times, and people saying, what are the outcomes if things don't change? There is limited research available on outcomes. However, the research that is available suggests the risk of death due to a baby receiving too little oxygen during labour is reduced by 25% if there's a fully staffed consultant-run service. 25%. That is a significant impact on future children's health if that service isn't provided in that way. I'm happy to take any questions on that section report.
Chair, if I may, can I make two sort of almost comments stroke questions? I think the challenge about looking at paediatrics maternity at the FireEdge is just one of the many challenges we are going to face into the future in terms of healthcare. Because what we now know is that senior clinicians are better at looking after sick people. And it's pretty self-evident, isn't it? But we also know that people who have high specialization need to be seeing enough patients to keep their skills up, as you pointed out earlier. And so this process is one that's not just suddenly started with pediatric maternity. It's happened, for example, in terms of the way we look after people who've had heart attacks. You know, I first qualified, they used to come into hospital, they'd spend 2 weeks in a bed. Now they go to a specialist centre and come up better than before. And I could go on with examples of stroke, etc., etc. The other thing that's also happened, I think, in paediatrics is that when I first qualified, far more children were admitted to hospital. If I'm honest, primary care didn't manage things like asthma as well as they do now, partly because some of the drugs weren't available. And now, I am a GP who does have ours. The number of kids I admit with respiratory problems has gone down significantly from when I started as a GP 20 years ago and when I started as a doctor 30-odd years ago. And also things like immunisation, etc., etc. And so the number of children going to hospital is reduced, but actually our expectations of care, quite rightly, have gone up. And so everything is this balance, and that I think I want to try and say to the public, it's that real debate about the balance between access but also quality of care, and you get there. And I think that some people think that maybe we've just come to this decision in a sort of a rather slapdash, quick way. There's been a great deal of consideration and anxiety and debate internally and externally about that real balance. But what's evident is that sometimes it's better to travel a little bit further to get high quality care, because the evidence is suggesting that that distance is outweighed by the people who are delivering the care at the other end. I'm sorry, it's a bit of a statement, but I think it's really important that we thought about this case for change really deeply, and we discussed this really, with a great deal of sort of almost heaviness, I suppose, to make sure we came to what we hope is and we feel is the right decision.
Thank you. Any other comments or questions on
Like Linda, I don't have a medical background, so for me the key issue here is outcomes. And outcomes isn't a dry academic subject, it's the difference between life and death. So I would like to ask a question of the clinicians about outcomes. Are we assured that option 1 will give us the best outcomes, i.e. more people will live than the other options?
Well, I would hope that. I mean, I think it's difficult. I think what we have is the Royal College, who have given us a lot of standards, and those standards are based on trying to get the best outcomes for patients, and that's because actually the published evidence about outcomes is not huge. There is some. I think the important thing is that, and we've actually included the article from the BMJ in the papers, and it's what Henry talked about. There is unpublished evidence locally which actually also reflects exactly the same as this. It cannot be published because if it was published, the deaths it mentions would be attributable to individual people. So if you like, it's there, but it can't be published publicly because the number of deaths is small, so it will be attributable to individuals, so it can't be. But I think what it does is it confirms what we found in the BMJ, and what we're looking at is, you know, moving all maternity units to eventually, if they're big units, having a consultant present in the hospital 168 hours a week, so that there is somebody on the labour ward every hour of every day. At the Friarage, there at the moment, the consultant is present on the ward 40 hours a week. Talk briefly about paediatrics, and I think that what we're talking about is at the moment in the hospital as we speak. What we have is at night we have a junior doctor who's training to be a GP present in the hospital, and a consultant at home on call. That junior doctor, who may only have done a week of paediatrics and at most will have done up to 6 months, is basically the person who assesses poorly children. So if you have a child on the paediatric ward who is sent in by their GP with, say, a respiratory illness, who very quickly shows signs that they're actually developing meningitis, they need some intensive therapy. They would then call the consultant in from home. If at the same time there's a woman labouring on the labour unit who then has a baby in distress, those are the 2 doctors there to resuscitate both children. One senior doctor, one very junior doctor. And when I speak to the consultants who run the service, they tell me that they have felt fearful in those situations, that they do not have enough people to adequately resuscitate those 2 children. What has happened in the past is the consultants who have supported the unit live very, very locally, and when they are not on call, the consultant who is on call has phoned them up, and they have come in when they're not on call to help out, and that has happened regularly. Now, I don't think that is a situation that you can't have a service where the safety is predicated on the goodwill of consultants who are not on call.
Okay, taking into account all of these issues, NCAT were involved in helping the CCG look at the options available to address these concerns. Out of the engagement process, which originally had 7 options, it was distilled down to 3, and of one of those was at that time the PCT, who were the statutory authority overseeing the services, discarded one of the options because they said it was not deliverable, and therefore we shouldn't consider it as an option when we consult. So there was 2 remaining options which were distilled down for the future of the Friarage, and I'll summarise those very briefly. The first option was to develop a midwifery-led unit and to develop a paediatric short-stay assessment unit. That would allow women to deliver locally in the Friarage Hospital when it was clinically appropriate to do so. And it would allow children to be seen through daytime hours up to the evening if there was concerns about their health. The option would see the continuation of delivery of the community paediatric nursing and consultant paediatric outpatient service at the Friarage, where the specialist services would remain as they are now at James Cook, Darlington Memorial Hospital, Harrogate District Hospital or York Hospital. The second option put forward consisted of all of the above other than the paediatric short stay assessment unit. So there was two options, one with a paediatric short stay assessment unit and one without. At the end of the consultation, as you have heard already, we did invite other parties to submit options of how they feel we could continue the service, and we received 3 further options to consider. I'm going to go into the detail of those later in the report as they're detailed. But at the moment, the preferred option for the CCG remains option 1, which is the midwifery-led unit, the paediatric short stay assessment, and the continuing delivery of all the appropriate services that are there at the present time. Do people want to question any of that part of the report? Okay, moving to, I said at the start of this meeting the responsibilities and accountabilities we have as a governing body, and one of those is to consult with the public and involve the public in the decisions we have made. In the public consultation and engagement process, as outlined on page 36, it specifies that we have a legal duty to consult with patients, public and the local authority overview and scrutiny committee. As I said, we ran 10 engagement events in April, June 2012. Out of those engagement events, the key issues were around the long-term future of the friarage, clinical safety, issues around open access children. They're the children who have chronic long-term illness who presently receive services on an open basis at the friarage. There was issues around transport, issues around integration between health and social care. And at that stage in the process, we had 600 people who gave us their views for our survey. We then took the proposals of what we were hoped to do with the service at friarage to the Overview and Scrutiny Committee, and after a meeting they had, they decided to refer it to the Secretary of State for Health. I'm not going to go into the detail of that, other than to say we then got last year, about April, May time, a view back that they weren't going to fully review our proposals, and they wished us to do a full public consultation. So from page 38 onwards, it outlines that from September to November 2013, we undertook 9 public meetings. We had a number of fact sheets to explain the issues. We had meetings with key stakeholders. We presented a DVD. We met with mother and child groups. We involved local GPs. We involved the media, newspapers, radio and TV, and we ran another survey. Interestingly, this time we received 76 responses back to that survey as opposed to the 600 responses previously. I think part of the issue there is that the first engagement process, people were reading that this was about the Friarage Hospital closing, which it wasn't, as opposed to the changes to maternity and paediatric services. And I do wonder whether the response in the surveys reflects that, because it's quite clear that the Friarage Hospital has a long-term and viable future. At the end of this meeting, I'm going to summarise those key issues the public told us about and relate them to our recommendations, so we can here today see that we have listened to the public and we've related our proposals to their issues. Again, can I have any comments on that part of the report?
Henry, do you think we've covered sufficiently the issue of the friarage staying as a essential to healthcare in the locality?
I think that's one of the areas at the end of the meeting I thought we would reiterate, because it came up both in the engagement process, in the consultation process. And as I say, we have, as an organisation, committed ourselves to the friarage as a vibrant long-term facility. The Trust have also committed themselves to that vision for the friarage. So I think you're right, we need to keep on saying it, Charles, I think. I'll now move on to the additional options, which are on page 44 of the report. The independent reconfiguration panel suggested in their feedback to us that we consider additional options. The additional options we received were from Andrew Newton, David Williamson, and Richmondshire District Council. Each option was discussed across 2 meetings. The CCG chaired those meetings, and we invited the authors of those proposals to meet with us and the clinical staff from South Tees. The authors presented their options, and the clinical team questioned the options to find out what they felt were viable and what they felt was not. I think it's fair to say that throughout this process we've tried to take the best of those options into our considerations, because they all were merited, they all involved a lot of work by the authors involved, and we should thank them for that time and commitment. We also asked NCAT to review the options. They, as we've spoken earlier, concluded that none of them were clinically viable. In summary, we did take elements of the options, particularly Andrew Newton's, and we incorporated those into the CCG preferred option. And again, can I ask any comments or questions on that section of the report?
Perhaps I could just comment on a question about why we chose NCAT. I think NCAT is the National Clinical Advisory Team. Their job is to review configurations. That's what they're statutorily set up to do. And they are, and they have been in existence for some time, for the last, I think, about 6 or 7 years. They are at the present being replaced by clinical senates, which are new organisations being set up and down the country. And I had a conversation before Christmas with the chair of the Northern Clinical Senate, which is our clinical senate, about whether they wanted to review these options or whether we should use NCAT. And their view was that because the NCAT already knew the issues here and had been here, and they were just setting themselves up in the north and therefore not really ready to take on this kind of thing, they were happy for NCAT, which will be in existence until the end of March, when it will be replaced by clinical senates. They felt it was best that actually that review should be done by NCAT. So, but what has happened is that we have sent the Northern Clinical Senate all the information about this. So they are also cited on what is going on in Hambleton and Richmondshire.
Thank you.
Chair, can I say something about all these options? I was sitting in on the Council of Members on the 7th of February, really as an observer from the community, and I heard all the doctors discussing all these options and all these variations in great detail. I also realised that all the information had actually gone out to the practices, and the practices had done their own homework, as it were. And the decisions reached on that day were from the clinical side of our patch. They were made with the best interests of their patients, who they knew very well. And the discussion led me... I was greatly relieved when I heard all the discussions, because every option and all points was raised. So from somebody from a non-medical background, I felt that the right people at the right time had been looking through these options and put that forward. Thank you.
Thank you, Linda. Any other comments, questions? We'll move on to the Equality Impact Assessment, which has been asked again in questions this morning. The Equality Impact Assessment is a statutory obligation consisting of the Race Relations Act, Disability Discrimination Act, the Equality Act, that we assess the impact of policies, strategies and services on the population affected by them, to ensure that no group suffers detriment as a result, and that positive action to improve community cohesion is taken whenever possible. The method involves a screening impact assessment, which is carried out against all of the protected groups to assess the positive and negative potential impacts of any change. We involved the Open Access Group in that as a key stakeholder group. The recommendations from the Equality Impact Assessment are in page 58 of the report, and they include strengthening the role of the GP, strengthening the role of telemedicine, enhancing paediatric community nursing cover, enabling health and social care to work more closely, and providing outpatients on a 7-day-per-week basis. Travel was a major issue throughout all of the engagement and consultation processes, and therefore in the recommendations we addressed that specifically with 3 recommendations about how we support people in getting both emergency care, getting access to outpatients, and a taxi subsidisation scheme. At the council members' meeting, this again was seen as an important element of responding to the public concerns on this particular area. Again, at the end of that section is on page 61. I'm happy to take any questions or comments.
At this point in time, I'm not sure that you have that peace of mind in terms of disrupting the conduit between the communities and the hospital they had great confidence in, and being told they had to go elsewhere in the future.
I'm happy to register that comment, and we will respond in due course. We will continue with I'm happy to do it at the end of the meeting. I'll now move on to the assurance process by which we have addressed this issue. On page 62, the Secretary of State for Health has set 4 reconfiguration tests. These are that they need the support of clinical staff and GP commissioners, that they strengthen public and patient engagement in the services and the role of the local authority, that there's clarity on the evidence base, and there is consistency around current and prospective choice for patients. Pages 62 to 65 of the report sets out in detail our response to each of those areas and concludes that we have fully met the test and can provide assurance to our key stakeholders to that effect. Again, I'll pause at that point for any comments or questions.
I'd like to point out engagement of the public. I know we tried very hard to get the news of the meetings out and the news of the consultation out to the users of the service. Do you think there's anything more we could have done to have reached mothers and fathers of children and prospective mothers and fathers to be more involved in the consultation process?
I think it was a frustration for us. I attended most of the meetings. We put them in the media, local medium. They'd been announced through radio and TV. We did circulars, so I'm not sure how much more. I'm happy to take comments to the counter that, but I'm not sure how much more we could have done.
I suppose I've thought about this quite a lot, actually, because we sent out flyers through the local authority to every school, every playgroup, every children's centre. We sent them to every supermarket, every small convenience store, and asked them to put them up. But clearly, we didn't get people coming. I think that the only other option we could look at, and I think it's something that we need to be thinking about for the future, is should we be doing a mail survey of some kind of sort, where we actually do something like the GP Access survey, where you actually send randomly written questionnaires to a certain number of households. I mean, obviously there's an expense to that, but I think that, and that isn't what is done when we're doing consultation around the country. But I do wonder whether actually, particularly going forward, as I think there'll be more changes to health services, we need to think of innovative and different ways to involve the public.
Thank you, Vicky. Any other comments on that section?
I did want to say about the GP consultation, the fact that we were allowed to express our views in a new way we'd never done before, by scoring things on a very structured manner, and I felt that would allow GPs to express how they felt about each service.
The only other thing I just wanted to mention really was if we talk about the evidence base, and I think there has been some comment from the public, which perhaps we haven't actually gone into, about the 2.7 million, what a lot of money that was, and I think it is fair to say that if we can explain the 2.7 million, the 2.7 million was what we asked the Trust to develop a model that met all the Royal College standards. So that's what we asked them. That was the question. And actually, if you look at what happened in Banbury following the IRP that was overturned there, and the Strategic Health Authority asked Banbury to put in a service that was compliant with all the regulations, their service cost about the same amount of money. So for a fully compliant service that meets all the standards, that makes it safe, which is our bottom line, it would cost 2.7 million. All the other options are basically using a different model. They're papering over the cracks. They're all models that have inherent anxieties about safety. They don't comply with the Royal College guidance, and all those areas and hospitals are in a queue behind us, having the same conversations with their public.
Chair, can I just come in on that? I think... Be feeding back, sorry. I think it's important that people understand that this problem is not fundamentally about money. What it's about is the knowledge base which is now required of consultant paediatricians and the fact that medical knowledge has moved on. You may remember, taking a parallel in teaching, that many years ago it was possible for a teacher to take pupils from the age of 5 through to the age of 16. No reasonable person would say that is the case now, and so it is with medicine. It's no longer possible for a general paediatrician to have a sufficient knowledge base to look after all aspects of paediatrics in a small hospital. And that's why we have to address this. So to some extent, whether it's 2.7 million or 300,000 is not the big question. The big question is how is the future that we keep a paediatric unit properly staffed with quality staff.
Thank you, John. Any other points? We'll move on to the assessment of the options by the GP Council members, which is outlined on page 66. Pages 66 to 76 summarises the issue for the options and cost associated with them. While some elements of the other options submitted were incorporated, particularly Andrew Newton's views, the ANCAT did not support the other options as they were. Pages 72 to 76 presents a risk matrix for options 1 and 2. Again, on that section of the paper, is there any comments or questions? Sorry.
Just in terms of the point 1 there, the opening hours of the the Paediatrics Surveillance Unit, I think that it may be covered later on when you talk about the council members meeting, but that was an area that was really sort of intensively discussed as to the benefits of opening it 5 days a week or 7 days a week, whether it should be just in working hours or extended hours, whether it should start at 9 in the morning or a bit later on, and that, I think there was a lot of sort of clinical input from the GPs to sort of reinforce the benefits of that being a 7-day-a-week service, which is what we really want, and a service, especially during the week, that goes on till 10 o'clock at night, so it meets in with evening surgeries and the times when the vast majority of paediatric admissions actually happen, when there are very few admissions later on in the night and through to the early hours of the morning.
You're right, Mark, there was a great discussion about that, and I know for some members of the community they were quite clear that from their perspective it should be a 7-day service. While they understood the rationale for the changes, I think had we not agreed a 7-day service, I think for them that would have been a deal breaker.
Sorry, in a lot of ways, that service is a better service than is there at the moment, in terms that there will be a consultant present throughout the hours that assessment unit is open, and get quick decision, quick treatment, and better outcomes.
And I think that reinforces the theme around having the right people in the right place with the right expertise to make the right decisions. And now we'll move on to the extraordinary council members meeting, which was on page 77. It's been referenced today again already. On the 7th of February 2014, there was an extraordinary council members meeting of the CCG to consider the final recommendations for the future of the services at the Friarage. The meeting was videoed and available on the CCG website. 13 of the 22 member practices attended, and 9 practices provided a written submission. 17 of the practices formally scored the options presented. As Vicky's already intimated, that the Constitution states for any vote to be carried, it must have the majority support. That's 51% of the practices. The council members agreed with the prioritisation process and agreed to score the two options the CCG had previously shortlisted. It was a unanimous decision and therefore allowing options 3 and 5 not to be scored. Prior to the meeting, each of the council members was sent all of the documentation explaining the options, the additional options, and the information relating to the investments required and the decision-making criteria. All additional options were provided in full to all the practices. Each practice was provided with a template to score each of the options, and they were to return that to the CCG or bring them to the meeting. The preferred option voted by the council members was option 1. Pages 82 to 83 are a record of the key discussions on the key issues and the voting scores. Therefore, the conclusion of the meeting was a recommendation to us to approve option 1. Can I take any questions, comments on that section of the report? The report does, at the end, highlight some potential future risk issues and some key learning points for us as an organisation. I'm not intend to go through those in detail now.
Can I just make one or two little points from that discussion and the decisions that the councillor members made, which in some ways addresses sort of Councillor Blackie's point about access from the community to the Friarage, and the Friarage being a valued facility that we very much want to continue and grow and improve. I think, as we've discussed, having the paediatric assessment unit maintains that contact for the vast majority of people with children's problems to be able to attend the hospital, receive excellent service. But on the occasions when they and people who have had to be transferred for maternity side of things, we all voted for improving the transport access between the Friarage and the James Cook site, which is something which has been brought up and discussed at great length in lots of meetings on various issues. We felt it wasn't just an issue for the paediatric side of things. We felt it was fair access for families, for stroke patients who were transferred, for the major trauma that was transferred, to maintain those links both in hours and out of hours by sort of approving the taxi service as well. And I think it shows a sort of great commitment to keeping the Friarage as a hub for the community.
Thank you, Mark. I said at the start of this, I wanted to come back to what the public told us in both the engagement exercise and the consultation, and for us as a governing body to be assured that we've taken those into account in making our decision today. Key themes from the engagement exercise, April 2012 to June 2012. The long-term future of the Friarage Hospital. It's been commented on already. The CCG has made a commitment to the long-term future of the Friarage Hospital. We see it as being an absolute key part of our plans in the future, and we have no doubt it will continue to provide a valuable, high-class, high-quality service to the communities. I don't know if any other members of the governing body want to make a further comment on that. The second theme was clinical safety. Well, this has been the centre of all of the discussions. Clinical safety and our desire to make sure our population have the most appropriate services that are clinically safe to a high quality. We've made that argument throughout the last 2 years, and it's made again in the report today. I think we have at the forefront of our thinking clinical safety. I know that the decision that results from that being at the forefront of our thinking sits difficulty with some people because they want a service that's the end of their road, and it can't always be that way. So I think George articulated in his discussion, as John and Mark has, clinical safety is about getting to the right place with the right staff who've got the right expertise to deliver the right service. If you don't go to a service which has those features, then unfortunately you will be not having a safe experience. Again, is there any comments from the governing body on that point?
I just want to reinforce that, because when we started, one of our criteria that we were going to judge ourselves by was care as close to home where clinically appropriate. And I think that part of what we also have to do is to bring back certain services and to improve them in the community. And that's where I think Andrew Newton's contribution to the debate has been very useful, because he's actually talked about strengthening community services, making sure that where possible, children don't actually have to go to hospital if they've got complex long-term illness, that where possible it can be provided as close to home as possible. And I think that's going to be part of our ongoing debate as a commissioner, is how do we ensure excellence, but also accessibility and care where appropriate close to home. And we're going to have this debate constantly about where those lines are drawn. And I think that the paper talks about trying to support people close to home, but also when they need high-class care, when they're acutely ill, there is I suppose, a cost in terms of travel, but we feel that the benefit in terms of the expertise outweighs that in terms of outcomes. And so I suspect that we will constantly be having this conversation. And for me, it's about saying some specialist care you have to travel, but we want to pull back community care, outpatients, etc., so people can get that care close to home. So I know I'm going on about it, but I think for me it's an absolute mantra. One of the reasons why I became involved with the CCG and why I feel comfortable with my colleagues, because we've all bought into that concept of trying to pull things back where we can, but recognizing sometimes you have to go further to get excellence.
Okay, thank you.
I think it's worth reiterating that over the clinical safety, that issue was brought to us by the providers of the service. It was brought to us by the consultants in the paediatric department. They were aware that things were changing moving forward, and the service they were providing and are providing will start to fall short of expectations in the future. And they wanted to act before things went wrong and things turned bad. And they want to leave people with a good memory of a service rather than leaving people with a bad memory of a service.
Okay, the next thing that came out of this part of the process was the families of children with open access. And I think, do you want to comment on that, Vicky, how we've engaged?
I think we've worked very closely with them, and I think we have a whole raft of recommendations and work going on now that will look at particularly how we join up some of the community care. Some of these families have very complex needs, and they have input from social care, from education, and from health. And we've now got a working group together to try and pull together the organisations that provide that care, because we believe there's a lot to be done about making that care more effective. And Andrew Newton is on that group and supports us in that work. So that's a sort of a more longer term piece of work, but there's also a piece of work that Charles is leading, which is looking at how primary care can support those children more effectively in their communities. So there's a whole raft of work that's come out of that, which we will continue to work at.
Transport came up, and the proposals address transport on three fronts: about emergency care, about people having access to James Cook, hence the shuttle bus, and people getting out of hours having an option to use a taxi service if they are stranded at James Cook. And they'll come up in more detail in the recommendations. And the last one, that key theme from the engagement events, was the integration between health and social care. And I think it's fair to say through a number of fronts we are working with health social care colleagues to provide integrated services wherever possible, and that will continue. The key themes from public consultation had some of the same: clinical safety, which we've talked about; transport, which we've talked about; the future proofing of the Friarage Hospital, which we've talked about. The other issue that came up was capacity at other local hospitals, and we've sought assurance from Darnton Moor Hospital that they can cope with any increased activity around maternity and paediatric service, and they have given us that assurance. Patient choice was brought up several times, and again the report acknowledges that patient choice is central, but we need to work with each individual patient to make sure that they understand the choices available to them, what the implications of those choices are, and how they can be supported in making those choices. The sustainability of a midwifery-led unit has come up, and as Vicky has hinted earlier on, yes, it needs to be used to stay as a midwifery-led unit. If it's not used, unfortunately it will cease to function without the appropriate number of births happening there. Issues came up about the public consultation process itself, and this issue saying this is a done deal. Well, quite obviously, the reason I'm going through the detail of this report is that we've taken into account the comments that have been made to us, and we've altered our recommendations because of those comments. And today, the governing body is considering all of those issues in making its recommendation. I think the unique solution which we've all strived to find and been unable to achieve, I think again it's worth thanking all of those groups, Richmond District Council, David Williams and Andrew Newton, who've tried really hard to look at other options. At the end of the day, where it's possible, we've included those in our final recommendations. But again, we can't move away from the issues around viability and safety of the service. I'm now going to take the governing body through the recommendations one by one and ask the voting members, and the voting members for the public are from John around to Charles. So we are the voting members of the governing body, and I'm going to ask you to approve each of the elements of the recommendation as follows. So the first is we're requested to approve option 1, and in doing so, agree that the clinical case for change has been strongly made and other options have been considered. Are we satisfied to that? Can you have a show of hands, please, as to... Okay, thank you. That we agree that the views of the public have been sought and all mediums used to ensure a fair and transparent process has been adopted, and that the impact on vulnerable groups and those experiencing health inequalities can be mitigated. Are we satisfied to that degree? Again, show of hands. That we endorse the outcome of the GP Council members and the preferred option from the public consultation. That approving the overall, we need to approve the overall investment of a further £625,000 in order to provide 24-hour 7 ambulance service. That the special baby care, I can't say that, short stay paediatric assessment unit is provided on a 7-day basis. That there is a taxi services out of hours and a shuttle service, bus service in hours between the Friars Hospital and James Cook Hospital for all specialties. Are we approving that? That we agree that all the investment areas will be formally reviewed by the governing body after 6 months implementation period. Yes? And finally, that in making these recommendations, that we agree the implementation time frame of 6 months for the new service to commence in October 2014. Are we happy for that? That brings the end of the governing body meeting and our recommendations being made to go forward from here. Thank you all very much.